Assalamu alaikum. I hope my voice is clear. All right. Okay, let's begin with today's topic. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. I am Dr. Kanza Chandio, the CEO of Experience Dentistry, and the topic today that we are going to discuss is mastering radiographic technique from positioning to processing. My lecture is going to stay focused on the English language because we do have some international viewers as well, and I wouldn't want them to be restricted of this knowledge because of the language barrier. So, okay, do let me know if you guys want to repeat anything by the end of the lecture, and then fine, let's begin. Bismillah ar-Rahman ar-Rahim. Okay. First of all, we are going to see the learning objectives. Learning objectives are understanding the type of dental radiograph. We are just going to skim through it because that is not the main topic of this lecture. Then is the mastering position techniques of IOPA, which is then it is IOPA and lateral ceph and OPG. All right, intraoral periapical. I had a tongue slip. Okay. Then third is identify common errors in image acquisition and how to avoid them. Then we will review the basic image processing principles, the manual and digital. All right. Then we have why does radiographs matter in dentistry? It is essential for diagnosis, treatment planning, and monitoring. For example, if there is an infection on the tooth or the tooth root, there is cavity between the teeth, or there is an underfilling, there is some problem with the jaw development, like for the kids, the children, the teenagers who are just getting their permanent teeth. Then there's regarding the periodontal health as well. We want to observe the bone loss as well in the severe gum diseases, right? This is a non-invasive diagnostic tool and it complements the clinical findings very smoothly. Okay. All right. Then we have the overview of dental radiographs. The first objective. There are two types of dental radiographs, intraoral and extraoral. For the intraoral, the first one that we are going to talk about briefly is the periapical. Periapical is an intraoral X-ray that captures the entire root from the crown to the root apex, including the surrounding alveolar bone. The purpose is to make the diagnosis of periapical pathologies such as abscess or cyst, and then to assess root morphology, fractures or resorption, and then to evaluate the periodontal bone loss and to monitor the endodontic and surgical treatments as well. Right, you can see very clearly in this image that what type of X-ray is a periapical X-ray. We will go further into detail, so I'm not going to stay here for long. Okay, right. Then we have the second X-ray, which is the bite wing. Bite wing is an intraoral X-ray that shows the crowns of both the upper and the lower tooth in one image. Typically, we take this from premolars to molars. The purpose of this radiograph is to get a especially early stage cavities, interproximal caries. Okay, then it is to monitor restorations, for example, marginal integrity or overhangs. Right. Then we have to evaluate the crystal bone levels. Okay, for periodontal health specifically. Okay, then the other one is occlusion. Occlusion is rather a larger intraoral X-ray taken with a film or a sensor placed on the occlusal plane of the maxilla or mandible to capture the broad area of the jaw. The purpose is to visualize unerupted or supernumerary teeth and to detect their position perhaps and detect the jaw fracture, cyst, pathologies, and to evaluate lingual palatal swelling or foreign bodies. Okay, all right. Then we have these are the basic intraoral radiographs regarding dentistry. And the extraoral includes OPG, or known as orthopentagram or panoramic X-ray. It is a two-dimensional dental X-ray that captures the entire upper and lower jaw, including the teeth, the TMJs, temporomandibular joints, maxillary sinuses, and surrounding bone in a single image. Now, the purpose of this is the assessment of dental arches. So that we can evaluate the eruption patterns, missing or supernumerary teeth. Then it is to evaluation of the impacted teeth for especially the third molars, yeah. And then there is the orthodontic treatment planning, the bone levels, root angulations, the tooth alignment, and the assessment of the jawbone. You want to identify if there is a cyst, a tumor, or a fracture. TMJ evaluation. TMJ evaluation is rather gross. Joint structure symmetry. This is what we want to identify. Pre-implant or surgical planning and baseline records for the general and forensics use. Okay. Then the extraoral, we have lateral cephalogram, also known as lateral ceph. Yeah. The lateral ceph, it is a standardized side view extraoral X-ray of the skull that shows the bones and soft tissues of the face, jaw, cranium in a profile. It is one of the most important radiographs in orthodontic diagnosis and treatment planning. The purpose of this is to assess the skeletal relationship between maxilla, mandible, and the cranial base. This is to determine the growth pattern, for example, the vertical versus horizontal growth. Then it is to analyze the dental inclination and position. For example, the incisors could be retruded or it could be proclined. Then the evaluation of the airway space and soft tissues. And then it is to track the changes over time during and after orthodontic treatment using the landmass for precise measurements. Then lastly, the cephalometric tracing analysis is the most critical diagnostic tool used in the orthodontic diagnosis. All right. Then the last extraoral radiograph that we are going to briefly discuss is CBCT, also known as cone beam computed tomography. Now, the cone beam computed tomography is a 3D imaging technique that uses cone-shaped X-ray beam to produce detailed volumetric images of the teeth, jaw, and facial structures. Now, unlike the 2D dental radiographs like periapical and panoramic, the CBCT provides a high-resolution cross-sectional and 3D views, allowing us as dentists to make accurate diagnosis and treatment planning. The purpose of CBCT in dentistry is for the evaluation of bone density, height, and proximity to the vital structure in implant planning. In endodontics, it could help us detect periapical lesions, roof fractures, the canal morphologies, the most critical one when it comes to endodontics. And then the orthodontics to assess the airway space, skeletal symmetries, and eruption pathway. And in TMJ analysis to visualize the joint anatomy and pathologies, surgical planning for the impacted teeth, cysts, tumors, sinus lift, and in periodontology, the measurement of bone levels and detect defects. CBCT is a very, 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 very extensive topic, and it's very interesting because of the potential it has on how you can use this in your diagnosis and treatment planning. So as much as I would like to discuss it in this lecture, I just do not have the time limit to discuss it. So that is why I was not able to include this particular radiograph for the for our lecture today. All right. Then we are finally going to start with our topic, the techniques. I already said that I'm going to discuss IOPA, the intraoral periapical, the OPG panoramic X-ray, and lateral cephalogram. These three are very commonly and very widely used and available radiographs to make dental diagnosis and treatment planning. So let's learn more about them. Right, okay. So this is a brief overview, okay? I am not going to discuss this since we have a good amount to discuss in the future slides. So let's go ahead and start discussing. Okay. Before we actually get into how to hold the periapical sensor and the film, let's understand the radiograph itself just a little bit, just briefly, okay? So the distances that must be considered when exposing a dental radiograph are target to surface distance, target to object distance, target to receptor distance, okay? The inverse law describes the principle of dose reduction as distance from the source increases, okay? It is very much self-explanatory. Then we have the ideal X-ray beam used for imaging should be sufficiently penetrating so that it does pass through patient and react with the film emulsion and produce a good contrast between different shadows, okay? It should be always, okay, the most beautiful x-ray that you would want, the most ideal x-ray you would want, will have to be parallel, so that that means that it should not be diverging, okay. And we don't want it diverging because we want to prevent the magnification of an image, okay. All right. Then, lastly, it is produced from a point source to reduce the blurring of the edges and uh, edges of the image. This is a phenomenon known as penumbra effect. Now, what is this penumbra effect, right? Let's see this picture. The three diagram you see on your left side, let's see. Now, penumbra effect happens because the X-ray spreads out slightly as they pass through the tooth and hit the film or sensor, just like light spreads out, right? You hold your hand in front of a light and your shadow is in the wall, but not right behind your hand. It is either below, it is either on the side, it is either above or at the sideways, but it's not exactly behind your hand, right? That is something that you can understand what a penumbra effect is. Let's see, why does it happen, right? You can see these three images that are on the left side. You can see there's one point, then there's mid size, and then there's large size. So if there's a very small point, the x-rays do not spread out. The rays do not spread out, right? And it has the least possibility to create a penumbra effect. As 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 you go forward from the mid size to large, you are actually increasing the focal spot. Once the focal spot is large, what happens is that the chances of the x-rays start to spread a lot. When they spread, they give a penumbra effect. Now, what does this penumbra effect do to the radiographic image that we are producing? It does not give us the crisp image that we want. We cannot see the canals properly, we cannot see the edges properly, we would not be able to differentiate between the if there is a slight periapical cyst or anything. So your diagnosis will be compromised, and all this is happening because you as a dentist are not performing the x-ray appropriately, okay. Now, how do you want to avoid this penumbra effect is by making sure that the position is proper. You would want to reduce the focal point by keeping the film or the sensor as close to the tooth as possible. You will use a long cone technique. Long cone technique increases the distance between the x-ray source and the tooth, okay. Do not get confused if you do not understand it, because we will keep seeing lots of images in the slides ahead, and inshallah then you will understand. Okay, then we have the subject density and thickness. Subject density and thickness, the greater the subject thickness and density, there will be greater the attenuation of X-ray beam and lighter the image will be obtained. Let's understand the order of densities first. The enamel has a greater density than dentine, cementum, bone, muscle, fat, and air. The denser the object, it is called radio opaque, and the less dense it is called radiolucent. Okay, the factors related to the technique on how a dentist actually captures the radiograph is the patient positioning, placement and position of the film, and the angulation of the X-ray beam. Let's discuss them. Okay. All right. So there are 6 basic principles of projection geometry by Manson and Lincoln. They say that the focal spot should be as small as possible so that we can reduce the penumbra effect that we discussed previously, right? The focal object to object distance should be as long as possible. You'll learn that in the coming slides. The object to film distance should be as small as possible, and the long axis of object and film plane should be parallel to each other, okay? I'll talk about the pictures that are in the slides. And the X-ray beam should strike the object and film at right angle. There should be no movement of the patient, tube, or film during the exposure. Okay. Now, if you see the image below, the first image on your left side, this is what is called the ideal image receptor positioning. Okay, the receptor should be positioned to cover the prescribed area of the teeth to examine. If you want to examine, say for example, the anterior incisor, you would want to cover the whole tooth all the way to the root so that you can actually observe it. Okay, and make your diagnosis according to it. The receptor must be positioned parallel to the crown of both maxillary and mandible. Why? So that the X-ray beam could be uh, uh, perpendicular to the film. Okay. All right. Now, I am talking about something that is very idealistic, but we know that practical is not exactly ideal. So, you see, the anatomy of oral cavity does not always allow us to use these ideal positioning requirements, okay, to be satisfied. So, in order to overcome these problems, we have two techniques that have been developed in the periapical. It is the bisecting angle technique and paralleling technique. We are going to discuss these, okay? But there are more techniques that I will touch upon, okay? All right, next slide. First and foremost, paralleling technique. If you have the opportunity to achieve paralleling technique, always and always go for paralleling technique. Let's see why, okay? Paralleling technique, the tooth and the sensor are both capped on the parallel planes. You can see on the top right picture how the X-rays are coming and how it is making a 90-degree angle with the sensor, right? That is what we call the parallel planes, okay? This technique actually provides less image distortion and reduces excess radiation to the patient. So it's like, two birds with one arrow kind of stuff. All right. So what does this do? It actually gives us diagnostic accuracy, measurements and length estimations because the magnification is very less. Then we have visibility of structures and it reduces the radiation dose. Now, the paralleling technique should always be attempted before you try to do the other techniques, right? When the alveolar crest is considerably atrophic, you should perhaps use a small size of detector to reduce the risk of distortion. Yeah, and you can see in the picture below that this on the first picture, which is basically noted A, it has short FSD. What is FSD? FSD is full form is focal spot to film distance. If it is short, the X-rays will be divergent. If the X-rays are divergent, the magnification will be not accurate to as the tooth is, okay, and you will not be able to make your diagnosis appropriately. All right. And of course, not many of your X-rays will be perpendicular, making a 90-degree with the film, which we want, which is the whole point of paralleling technique. So what you do, this is one of the principles that we discussed previously by Manson and Lincoln, that you should have long FSD, long local, focal spot to film distance. This will make sure that the X-rays go parallel, and when they travel parallelly for as long, the film sensor is as close to the tooth as possible, it will reach the film sensor before it can diverge, okay, and it will make the 90-degree with the film, and it will give you a very good crisp clear X-ray that you can make the diagnosis of. All right, I hope that was clear. This is the paralleling technique. Best of all, you should always attempt this before you try anything else, okay? Then we have now paralleling technique may sound very idealistic, but doing it without anything is not humanly possible. So we have made something very helpful to us, which are known as the cone indicators, or it is known as the film packets, or they are known as sensor holders, okay? And so you can observe that in this picture, you can see the first black and white picture that you see. There are some parts mentioned about this film packet or sensor holder or cone indicator. The Let's talk about the most left part that they have pointed out. I don't have a pointer with me here, so that's why I am trying to be as pointful as possible. Okay, so you can see that it says image receptor support and holder. This is where the sensor goes. This is where you keep the sensor, and this particular thing holds the sensor with it so that it does not fall. Then with it is the bite block. We'll discuss that. How does that help? What is the significance of it? Then you have a ring locator where basically you place the collimator, and then you have a metal arm on which you can change the distance of the ring locator. Together, the ring locator and the metal arm together are known as beam aiming device. Now, if you look at the picture below this black and white picture that has blue cone indicator, these are basically, you can even see it says 2, 1, and 3. These are basically for the anteriors, the anterior maxillary and the anterior yes, mandibular. So these sensors are normally the size of 22 by 35 mm, and if you can see that its long axis is vertical. Yeah, so if you would want to take the image will be for you will to capture the anteriors, you will need approximately 4 images, and for the lower you will need approximately 3 images, and this is perfectly indicated in the picture. Okay, in B and D. Then you can see the yellow cone indicator. The yellow cone indicator basically indicates the posteriors of maxilla and mandible. Okay, 4, 5, 6, and 6, 7, 8. You can see in the C. Now these are normally 31 to 41 mm, and you can see its long axis is rather horizontal. Then these they basically for the upper, for the anteriors we needed for the maxillary at least 4, but however for the posteriors we need just 2 to cover all of the posteriors. Okay, and similarly with the mandible we just need 2 to cover one side, either left or right, for the posteriors. Okay, all right, let's see. Positioning. Okay, I'm going to discuss in positioning how to actually how do we actually fit these cone indicators. Okay, and hopefully you will be able to understand it better. All right, so first of all it says upper incisor. So the patient is, now understand this, the patient is positioned with the head supported. You can see the patient has her head support behind her, and so that the occlusal plane is horizontal to the floor. Okay, you can see that the holder and the image receptors are placed in the mouth. There is maxillary anteriors. In these, this that we are discussing is for the upper incisors. However, this can be used for all the anteriors of the maxilla. Okay. Uh, the image receptor is positioned sufficiently posteriorly so that it can accommodate the vault of the palate. Yeah, we want to keep it perpendicular. We want to keep it parallel. Okay, and you can see that the patient has the dentist has tried to place um, as close to the tooth as possible without actually tilting this sensor. Okay, and then the collimator is brought on the ring locator. Now like I said, the ring locator can be moved on the uh, metal plate. Okay, so you want to keep the collimator, you want to keep the ring locator as close to the mouth as possible, and then you will bring the collimator on it, and then you will capture and make an exposure and capture the image. You can see how crisp the image is. Okay, all right. Similarly with the lower, there is nothing as such difference. um, you just simply take the cone indicator, the sensor holder, and then for the mandible. Okay, and then you put the sensor in it, you place it where you want to take the x-ray. Okay, and then you ask the patient to bite on the bite block. It basically, when the patient bites on the bite block, it basically stabilizes the cone indicator, and when you're adjusting the ring locator, the patient is not moving from the position that you have said that you are satisfied with that of the sensor. Okay, and then you place the ring locator as close to the face as possible, as close to the tooth as possible, basically, and then ultimately it becomes as close to the face as possible. Then you place a collimator on the ring locator and then make an exposure and you capture an image. Okay, so this is an example of the lower canine. Okay, then we have for the posteriors. The posteriors, like I revised with you, the it has the long axis of the sensor is rather horizontal when compared with the vertical of the anterior. Yeah, the image receptor is placed in the midline of the palate. Once again, we want to accommodate the height in the vault of the palate, and then we make an exposure and capture. Okay. If we are talking about the lower, the Image receptor is placed in the lingual sulcus next to its appropriate teeth, and then you make the exposure. Okay, these are just examples I wanted to show you in case you wanted to see how does a patient look like when you are using these cone indicators. Okay, this is all about paralleling technique. Let's talk about bisecting angle. This technique is accomplished by placing the receptor as close to the tooth as possible. This means that you will tilt the sensor. The central rays of the X-ray beam should be directed perpendicular to an imaginary line. Here you are making you are imagining things. You have an idea about what is going on, and this is how you should perhaps take it. There is no specific indicator for you like a cone indicator. Okay. Um. Okay. Uh, so basically what we are doing is the central ray of the X-ray beam should be directed perpendicular to an imaginary line that bisects or divides the angle formed by long axis of the tooth and the plane of receptor. This technique, why would we want to use this technique when compared with the parallel? Because there are times when we cannot use the paralleling technique. For example, there could be poor access. For example, making an angle between tooth and film more than 15 degrees. You may, like trismus, yeah, that's also a case where you can't possibly use the cone indicator. Now, what is the disadvantage? It actually ends up giving you a low palatal height, okay? And that is one of the basic disadvantages. And it does not give you the image estimation that you would want for the accurate diagnosis. This is the bisecting technique. Let's talk about something that we all, as general dentists, I believe, feel confused at some point of time, but it's very critical, and everyone should have a very clear cut concept of this particular technique. Now, tube shifting, Clark's twin, buccal rule, parallax, slop technique, these are all the same techniques, okay? Nothing else. In this procedure, the X-ray tube or collimator is shifted to some degrees, either horizontal or vertical, for the second radiograph. This method also points out the spatial position of object, and the full form, the acronym of SLOB, stands for same lingual opposite buccal. Now, sometimes limitations like less lingual sulcus depth or stiff tongue, it might be difficult to use a film positioner. Okay, you would ideally want to use the film positioner or the sensor holder or the cone indicator, whatever you may want to call it. Okay, and then you would shift the collimator to take the slop technique. How and what is a slop technique? Let's try to understand that. I want you all to focus on the image that I've placed, the diagrammatic image on your right side. Now, you can see that there is a blue tube. This is the collimator, the X-ray tube, okay? And in front of it is an object, a triangle yellow and a pink rectangle. I'm gonna say yellow and pink, okay? Now, the yellow is placed lingually and the pink is placed buccally. I know this because I can see it. However, when you take an X-ray radiograph, you cannot tell if these two things are superimposing over each other. If two roots are superimposing over each other, you cannot identify which is lingual or which is buccal. Now, the way to observe and identify this is through the slop technique. Slop technique says it is same lingual and opposite buccal. What it means is that you shift the collimator to the distal side, and you make an exposure. When you make the exposure and you see on the exposure that the yellow image is on the distal side and the pink image is on the mesial side, this means that the yellow object is lingually placed and the pink object is placed on the buccal side. So that is why same lingual. Wherever you're moving your tube and the object moves with it, that is lingual, same lingual. And the opposite will be buccal. Similarly, with the mesial shift, when the collimator is shifted mesially, you will observe that the yellow object is now mesially placed and the pink object is now placed distally. This means that the yellow is placed lingually and the pink is placed buccally. Okay, you can look at the picture that I have positioned below. Okay. Usually in the premolars, you may observe that there are two roots that are superimposing over each other, and you may want to take a slop technique for it, either mesial or either distal, whatever you may be comfortable with. But with the passage of time, you get a hang of it. But as long as you understand the concept that I'm trying to give you here, you'll be good to go. Okay? Practice makes perfect. Remember. All right. Why would you want to take slop technique? This, like I said, it is all about the superimposition. This is the tooth number 31. You may not expect it, but here we are. It has two canals when you made a shift. Okay, so this is a very good example of why you may want to use the slop technique. Then there may be cases like a very mal-occluded teeth, or it is very crowded. For example, in this case, you can see that the canine is very much crowded. This is 4-3. You would want to ideally take a slop technique to understand where the roots are and how many roots are there. Okay? All right. Let's go ahead. We have the good IOPA, intraoral periapical. It will have correct anatomical area with at least 2 mm of periapical bone. The image should include the correct, yeah, and there should be no overlap of proximal surfaces of teeth. The teeth should have an acceptable definition with no distortion or blurring. That means that you're not, when you're making an exposure, everything should be still. The patient should be still, the film should be still, the tube should be still. Okay. Then the optimum density and contrast. This is to facilitate the interpretation of the dentist trying to observe and understand and read a radiograph. The film should be free of cone cutting and other film handling errors. The desired density and contrast for the film captured images will depend on the clinical reasons for taking the radiograph. All right. This is all about the periapical x-ray. I hope you understand the technique of periapical x-rays, its different techniques, and I hope you will be able to apply it in your clinical practice. Okay, orthopentagram or panoramic technique. The panoramic radiography should be performed in accordance with the manufacturer's recommendation. This is a very, very huge emphasis, and it's not just about the OPG that I'm talking about, that you should always read the manufacturer's recommendation. You should read the manufacturer's recommendation even when you're using different sorts of material. You may be using a composite, but the companies may be different. I highly recommend that you do read the manufacturer recommendation. The long paper that you get, you should definitely and absolutely read it as a qualified and educated dentist. So, read the manufacturer's recommendation, and patient should remain perfectly positioned while X-ray tube and image receptors, film, or digital sensor simultaneously revolve around the patient's head. The exposure time is set to allow for the image capture of one full rotation around the patient. We'll be talking more about this in the coming slides. So let's go ahead. Okay. Remember, positioning matters a lot. Staying still matters a lot. Okay. All right, so there are 4 basic anatomical planes used to properly position a patient. The alatragus plane, orbital meatus plane, which is known as the Frankfurt plane, and then we have the canine meatus plane, the median sagittal plane. So obtaining the panoramic radiograph is rather easy, okay, comparatively easier when we compare it with the PA. You just have to make sure that the positioning is very well for the patient. So you would want devices for positioning the head and supporting the chin for the precise positioning, okay? Before you actually allow the patient to enter the radiographic region, you would want them to remove all the metal objects. For example, they would be wearing any glasses or earrings or necklaces or any prosthesis. Even there will be patient with the dentures. You would want them to remove that, okay? If the patient has long hair, you should ask them to tie that up. If they have any part of the cloth that is covering their neck, you, like for example a hoodie or a shirt with a high collar like turtleneck, you would want them to make that space clear, okay? If the patient's guardian is accompanying them, For example, a child is getting an OPG, and you would want them to wear a lead apron. You should also give the lead apron to the patient's guardian. Okay, because they are going to be in the way of the exposure. Okay. So, you will first ask the patient to approach the unit. Do not position yet, just adjust the height of the unit to have the bite block appropriately between the nose tip and the upper lip. Okay. The bite piece is selected according to the patient's dentition. You should always use a sterile bite pick and cover the bite piece with a single use protective sleeves. Okay. In case the patient's teeth are missing anterior, okay, or it could be that the patient has very mobile teeth. It could be due to any periodontal health, or it could be that the patient is wearing dentures and do not have is edentulous, right? There could be XYZ reasons. So what would you do in those situations? You would use the chin support, okay? You would rely on that. Although the positioning may be compromised, but your main source of positioning will be chin positioning. Okay. All right. Then you will ask the patient to close their lips, push their tongue against the roof of the mouth. Then you will ask the patient to approach the unit. Now you will ask the patient to approach the unit, hold the handles, and make one step forward, bite on the bite block in the central groove. Okay. When the patient is making the bite on the central groove, make sure you tell the patient to bite by edge to edge incisors. Okay. You will ask the patient to close your lips, and yeah, I that's about it for now. Okay. If you think that like the panoramic x-ray, the radiograph, it rotates around the patient, and you may think that the patient is tall or the patient has broader shoulders, and it may come in between while the radiograph is rotating. So you will ask the patient to kind of tuck their shoulders inside while the exposure is being made. Okay. Cross over their arms or handles, something like that, so that they can just tuck their shoulders inside. But there may be cases when the patient may be too tall and your machine is not as tall. You will make the patient sit without a backrest. Make sure it's without a backrest. You don't want the backrest in the image, right? You will have to make sure that the patient is seated uprighted. Okay, because we want the spinal cord to be straight as possible. All right. So why would you want to ask the patient to put their lips or to the palate? You can see those. It's a very basic concept. You can read the table. Okay. We don't have that much time that I would go into every single detail. Okay. I'm just going to stick with the technique. Okay. Now you will stand behind the patient and check in the mirror. The first picture you can see, this is a mirror. You will check if the vertical sagittal beam is aligned with the patient's mid sagittal plane. The dashed line in the picture is the mid sagittal plane. If it's not, then you will adjust the position by moving the patient's head. Okay. Now, you will, in the second picture, you can see that you will look at the picture from the right side. You will find the lowest point of the orbit. If necessary, you would want to take the consent and touch the patient's under eye, okay, and feel the edge of the bone under the eye. Then you will check the alignment of Frankfurt plane laser. This is a wide flare laser that appears as flat as you. You will adjust the Frankfurt horizontal plane in case you need one by a knob on the side of the unit. Okay. You want the laser to be aligned with the Frankfurt plane. Then in the third picture, you can see that you will gently move the patient's head so that the Frankfurt horizontal navigation beam is aligned with the ear canal. When patient starts to stand on his toes, adjust the height of the unit and try again. Okay. Now I told you, if the patient is tall, you may want the patient to sit on a stool without a backrest. Or if there is a child who is really short in height and the machine just does not get there, you would give them a stool so that they can stand higher. What if there is a patient who is in wheelchair? So you will make sure that the wheels do not collide with the machine base. Okay. Then at the end, in the last picture, you can see that you will ask the patient to smile while is biting on the block, and you will adjust this beam with the middle of the canine tooth. Okay. The newer machines have this specific feature. Okay. All right. What you will do next is you will now take the image. You will, before leaving the room, you will ask the patient to swallow and leave the tongue in the upper palate and relax. You will watch the nose tip in the mirror, and you will ask the patient to breathe normally through their nose and relax. Okay. Then you will press and release the exposure release button on the hand switch. The unit will start to move, okay, to the start position. Move. It will move behind the. Now you will move behind the shielded area, where you can see the patient. Okay. When the computer is ready, you will see a green indication in software. This means that the patient is ready, the environment is ready, and you are ready for the exposure. You will press and make sure you hold the exposure button in the hand. In the beginning, when people do not know it, the radiologist does not know it, they're still in the learning phases, they just press it. So make sure you do not do that. You press and hold the exposure button. You will hear a sound beep. The radiation, this means that the radiation is in progress. Okay. In software, you will see this as blue indication. In some panoramic devices, if the patient ends up moving, there is a compensation of up to 1.5 centimeter. Okay, so it does compensate with the image that we get. Now only after the sound stops and the unit stops moving, which will give you a yellow indication in the software, you will release the exposure release button on this hand switch. Okay. Now, when you leave it, there will be an image on the monitor. You will press and release the exposure release button on the hand switch, and the unit will move now to the exit position. In the beginning, you moved it to the start position, and now it will move to the exit position. After that, you will ask the patient to leave the unit. Now, in case of patients of childbearing age, you should definitely ask them of pregnancy. If pregnancy is not an absolute contradiction for radiography, it should perhaps be delayed after birth. Okay. All right. We are talking about the dental x-rays. So the least amount of the x-rays you will get is in PA. So if it is an emergency and if it is a specific dose, you would want to take the PA instead of an OPG or lateral ceph or any other exposure. Okay. All right. Once again, I'm not going to go through the whole table. The purpose of putting the whole table and such a detailed table is so that you guys can read and understand, because I have told you the whole concept of the positioning. And hopefully, when you will read through this, you will understand that why such position, if you do not position the patient in the correct position, it will result in a not good image, and you may want to take the image again. That means you will be exposing the patient to the radiations again. Okay. So as a ethical practitioner, you will want to avoid that at all cost. All right. So just like good IOPA, good OPG is when all the upper and the lower teeth and their supporting alveolar bones are clearly demonstrated. The whole of mandible should be included. Magnification in vertical and horizontal planes should be equal. The right and left molar teeth should be equal in their distal dimensions. The density across the image should be uniform with no air shadow above the tongue, creating a radiolucent band over the roots of the upper teeth. The image of the hard palate should appear above the apices of the upper teeth. Only a slightest ghost shadows of the contralateral angle of the mandible and the cervical spine should be evident. Okay, there should be no artifact shadows due to, for example, dentures or earrings or other jewelries. Then the patient identification label should not obscure any of the above feature. It should be clearly outside the radiographic image. Okay. And the image should be clearly labeled. This is very critical. The image should be clearly labeled with patient's name and the date of examination, because after 1 year the radiographic images expire, and you may want to take the image again if needed. Okay, if needed. As a dental practitioner, you will make the decision of that. The image should be clearly marked with right or left letter. This is all about the orthopentogram. Now I will briefly go through the lateral cephalogram. Okay, let's see. This is the bird's eye view of lateral cephalogram. The position is with the cephalostat, the head holder, that goes into the ear canal, the external auditory meatus, then the Frankfurt plane parallel to the floor, teeth in centric occlusion. The image features will be soft tissue profile, skeletal relationship, and airway visibility. Okay, all right. So one thing I have to mention is that Ceph must be reproducible and it should be consistent with the growth comparison and treatment process because like I said in the earlier slides, the lateral Ceph is a very important diagnostic tool for the ortho treatments. Okay, so it has to be reproducible. The lateral Ceph technique. The patient stands with the sagittal plan perpendicular to the film and centered over the sella turcica. Okay, remember, the OPG and lateral Ceph, they depend highly upon the proper positioning. If the position is not proper, the image will be compromised 100%. The craniostate is used to help position the head. Okay, the ear rods are placed in the external auditory meatus. Okay, then the nasion is aligned to on the bridge of the nose. You can't see that in the picture because it isn't mentioned. I'll show you in the coming slides. The Frankfurt plane must be parallel to the floor. Frankfurt line being line from the orbital to the tragus. Okay, this is a black and white picture, but if you go to the radiograph and get an lateral Ceph, you will see that for the calibration, they will have laser beams. Okay. All right. Then we have the teeth must be in centric occlusion and lips must be relaxed. I cannot emphasize enough on the lips relaxed because I myself in my practice have found so many images that the patient's lips are not relaxed. Like I said, the the lateral Ceph is mainly used in orthodontic treatments, and in orthodontic treatments, it is very important to understand whether the patient has competent lips or incompetent lips. And when you're doing the cephalometric analysis or tracing, you do make a soft tissue analysis based whether the lips are competent or not. So if the patient goes and is instructed by the radiographer to bite and close the teeth, they usually end up closing their teeth forcefully. Okay, so if you have as a dentist made a diagnosis that this patient needs a lateral Ceph, please do write in your prescription pad that take the image in relaxed lips position. Okay, you know it, you need to pass this instruction so that the patient is not unnecessarily exposed to the radiations again and again. Okay, like I said, the laser guides align the mid-sagittal and canthomietal planes. You must maintain the source to film distance of a 150 to 180 centimeter, which is 5 feet, and film to mid-sagittal plane distance of 30 centimeter. So I was telling you about the nasion, how to align the nasion. So in the picture on the left side, you can see the cephalogram. It has a ruler. This is how we position the nasion. This is how we align the nasion. Okay, it has a little ruler here. This is for the calibration. Will not go in detail because that is not the purpose of this topic today. Okay, all right, we are done with the positioning of basic. We are done with the technique of IOPA, OPG, and lateral Ceph. Okay, the good quality diagnostic qualities will be clear undistorted images, proper contrast and density, minimal retakes means less radiation, and regular equipment calibration. Always apply the LARA principle, which means as low as reasonably achievable radiations. Okay, in the picture that I've added here, the table that I've added here is the dosage, radiation dosage of the periapical and the panoramic and the lateral Ceph. Okay. All right. Let's go manual processing. Let's hop on to the processing for once and all. I am going to discuss these, okay, but not too much in detail, but just enough for you to understand all. Okay, manual processing is a chemical method. It is used to develop the dental X-ray films. It involves immersing the exposed film in series of solution under the controlled conditions. What are the steps in the manual processing? First is the developing. Developing converts the exposed silver halide crystals to the black metallic silver. Then the second step is rinsing. This is to stop the development process. Third is fixing. This removes the unexposed crystals to make the image permanent. Then fourth is washing, which eliminates the residual chemicals. And fifth is drying, which prepares the chemical for the viewing or storage. Okay. The film processing solution should always made up to manufacturer's instruction. Again, manufacturer instructions are very critical, especially if you have your own dental practice. You should always take some time out and read the manufacturer's instructions of the products that you have bought for your patients, right? Always at the correct temperature, change regularly. Okay, the processing solutions ideally every 2 week and monitor for deterioration. The advantage is that it is cost effective and it doesn't require any digital equipments, but the limitations is that it is time consuming and it is very prone to human error, like for example the temperature, the time, the contamination, and it requires dark room setup and chemical maintenance. Okay, this is all about manual processing. Let's hop onto the digital processing. The digital processing is the one that uses electronic sensors. Okay, for example, the CCD, CMO, PSP. Let's discuss them ahead. Okay, to capture and process the digital images instantly via computer software, eliminating the need for chemicals. Now you see, as the technology advances, the digital detectors are actually gaining in popularity since they are considered the part of optimization to reduce the radiations. Okay, and it maintains the high quality image as well. Now, in addition, we need to connect it to the computer and they are scanned after the exposure. Very easy for us, very convenient for us. Okay, most of the even the tertiary cares have a sensory units with them, the digital processing with them instead of the manual processing. Hopefully, manual processing will go obsolete because I personally am not the fan of that. Okay. Types of digital sensors. There is a direct digital sensor and there is an indirect. Direct means the first picture that you can see that I've added with the loop of so much wire. Okay, this is basically the one that uses CCD and CMO sensors. You connect it with the laptop that has a software in it, and then this black box is the sensor itself. Okay, then there is an indirect digital that uses PSP plates, the phosphorus plates. Okay, you take an exposure on a sensor and you put it in a sensor reader. Okay, and then it detects, reads it, and transfers it to the computer. Okay, all right. What are the advantages and disadvantages? The advantages are that you have an instant image viewing. Okay, easy. You can enhance, you can change the contrast, you can change the brightness. The radiation is very low. It has easy storage. You don't need to have any cabinet. You just need one monitor, CPU. Okay, and that's about it. And then sharing, retrieval, you can share it very easily. Everybody has mobiles. You can just share it with your experts that you may want to consult with. Limitations are that you do need a higher initial equipment cost, but in the longer run, it is cost effective. And it requires software and training, so it is a bit technical, but honestly, with the coming age, they are trying to make it as easy as possible. So if you take some time out and take the training, very easy, very convenient. And it does have sensor fragility, so maybe perhaps the maintenance may take a while, a bit of your money. Okay. All right. Okay, so this is all about the processing, the manual, and the digital. I hope that was more than enough for all of you. The time, we're short on time. The last thing I would want to discuss with you all is lead apparence in pregnancy. What is the evidence? So, these are the references that I've added for you guys, and I would highly recommend for every one of you to read these guidelines and these references. The first point says that the ADA no longer, the American Dental Association no longer recommends lead apron or thyroid collars for any patients, including the pregnant woman, because the modern digital X-ray system deliver minimal exposure and tight beam collimation that provides sufficient protection. Now, this is for the IOPA, okay, periapical X-rays. The second one is for the European guidelines. Okay, this says that the European Dental Radiology Guidelines state that there is no need for lead apron in routine dental imaging, even for pregnant women. The IAEA notes that fetal and breast doses from the dental X-rays are extremely low, typically less than 10, making aprons largely unnecessary. See, your exposure is completely towards the oral cavity, it's not towards the fetus. Okay. So, if, however, you are making an exposure towards the fetus, for example, making an exposure for the for the maxillary occlusal radiograph, yeah, so that you may want to take in consideration with, because the rays may be directed towards the fetus. Now, in the second last, the Jesus et al. In 2014 evaluated that fetal dose with and without shielding during dental imaging using phantom models. The upper estimates of fetal doses varied from 0.009 to 6.9 with lead shields, and the fetal doses varied from 0.005 to 2.1. There is no evidence to justify routine use of abdominal shield in conventional dental radiograph. Now, this is a study of 2014, okay, and the guidelines have been changed since past year, and we still have the stigma to use the lead aprons. Okay, so if there it may be a case where you do not use the lead apron, you should be confident because you are educated and you can give the literature review as well. Okay, the optimal safety, like I was saying, the optimal safety relies on the proper technique, the collimation, digital receptors, and not on the shielding. Okay, you would want to keep the radiation as low as possible. So the prestigious organizations like ADA, IAEA, European regulators agreed that the lead aprons are no longer routinely necessary. So wearing an apron can actually be an interference with the image quality and increase repeated exposures, which is counterproductive. Okay, so once again, I highly recommend you all to read these guidelines. All right, so takeaway. Positioning is everything. Accuracy matters. I've been repeating this throughout my presentation. You must know your anatomy. That was not the topic of my lecture, so I have to emphasize that you must know the anatomy, the radiographic landmarks, and the image processing quality impacts the diagnosis. Okay, the better processing you have, the better quality you will get, the better diagnosis and accurate diagnosis you can make. Keep practicing to master the technique. Okay, do not run away from it. Oh no, I don't know it, how will I do? Well, now you have the information, you have the knowledge, so perhaps start practicing. Okay, and you'll do good. Okay, all right. Any questions and answers? This is the session we'll have for at least 2 to 3 minutes if there is no question and answers from the audience. Oh Lord, I am tired of giving the lecture for the whole 1 hour. Let's wait. Okay. So feedback form have been submitted to you all in the comment section. Please kindly fill that for the purpose to ensure that our future lectures are how we can make our future lectures better. And yeah, I think there are no more questions. What do we have? Oh, hi, Simi Paxlial J from India. I'm sorry if I'm not pronouncing it right. Dr. Kim says, very good way of explaining. Thank you. Thank you. I put my heart and soul into it. SNJ says, easy to understand. I'm glad it's easy to understand. I hope it will be useful to you in the future. And Rian Lohana says it was very easy to understand. Thank you. Thank you. I'm glad. I'm really, really glad of this. Zainal Abidin says, very well explained. So you guys agrees with him. Okay. All right. I would want to ask you guys the questions. These are the questions. what is the most accurate technique for taking a practical for taking a periapical radiograph? I don't think I would wait for it. I want you guys to drop me a comment under this video because it will be recorded and uploaded. Okay. And the second question and third question and the fourth question. Let's see who gets it right. Okay. All right. All right then. These are the references for my slide. I hope it was helpful to you guys, and inshallah, see you guys until next time. Okay then. Allah Hafiz. Bye.